when we do that, we can actually cure that tumor in real time. So it's actually one of the most rewarding things that I do, because a patient comes in the morning with, let's say, a liver cancer, and I can ablate it, and I treat it, and they go home the same day with a Band-Aid and cancer-free.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Meena McCary. Meena is a specialist in interventional radiology. That's radiology, which refers to imaging, not to be confused with radiation treatment. In interventional radiology, Meena and other experts utilize advanced imaging techniques to pinpoint the exact location of a cancer, and then using minimally invasive surgical techniques, such as inserting a thin wire through a pinhole, they direct treatment to the exact spot where it's most effective. There are several advantages to these procedures, and it's a growing field, and Meena will fill us in on interventional radiology. Welcome to the podcast.
Thank you so much, Steve. I appreciate the opportunity to be here today.
Well, I'm very fascinated by this whole topic, and I'm anxious to learn more. But first, let's talk a little bit about your background, which, from what I understand, is very Buckeye-centric.
That's right. Go Bucks. So I'm from Columbus, and I did my training here at Ohio State, and I had the privilege of doing my diagnostic training, interventional training, and I've been recruited to stay here as well in our department.
Wow. So what made, growing up here, what got you interested in science, in medicine, oncology? Any relatives who are in the field? Any parents are in the medical profession, or cousins, or what? There has to be some connection, maybe or maybe not. You're the first.
No, absolutely. So, it's the people. So I've always had interest in taking care of patients, or just the art of medicine, and also the science of medicine. And over the years, as I was going through school, my experiences kind of reinforced that. And then when I was in college, unfortunately, my dad, passed on my first semester of college from sudden, medical issues. And
oh, I'm sorry.
That, I see his face in every patient I treat. That kind of changed my perspective on patients. And every day I strive to take care of patients because of that. At
that point, were you already heading toward medical school, or is that the thing that changed your trajectory?
That was early on in my college experience. So I was interested in science, and I was learning more about healthcare in general and other areas. But that, and along other personal experience I've been through, kind of reinforced my interest for taking care of patients. And that's what keeps me going every day. It's the patients, despite the challenges or the difficulties or what we go through, is, when you're able to help and kind of see, the impact, it's just fascinating.
Yeah, you do that every day. That's what I'm always amazed at, that for a living, you and so many other people here save lives.
No, thank you.
So let's talk about interventional radiology, which I hadn't really heard of or know very, very little bit about. So give us a quick history on how it sort of came about and where you and other leaders in this field are today.
Sure. So interventional radiology is a cutting-edge area of medicine where we use technology to treat patients. And in the grand scheme of things, it's relatively recent. So the first interventional procedure was performed in 1964 by Dr. Charles Daughter. He had a patient who was about to lose her leg, I think 80-year-old or something like that, and they had occlusion of a blood vessel, and he figured out a way.
What's an occlusion of a blood vessel?
Blockage.
A blockage, okay.
A blockage of a blood vessel. And back at that time, there was no options, and the patient did not want an amputation. So he figured out the basis of our specialty, which is, as you mentioned before, using a pinhole incision, going into a blood vessel, and using wires and other devices. And he created all those at that time because there was nothing on the market. And then he helped that patient, and then since then, newer and newer technologies developed, and our specialty was recognized in 2012 by the American Board of Medical Specialties as its own specialty. So it's only 10 years old officially.
In the surgery you just described on that woman, he used the minimally invasive surgical techniques, but where did the imaging come in on that? I mean, I know you weren't there or anything, but that's sort of the other main part of this, right?
Right. So that's a great question. So the imaging is what he used to, what we call it as imaging guidance. So he used it to see inside the body so he can manipulate his devices, because if you make a tiny incision and insert a wire, you don't see where it's going.
Right.
So the imaging helps us see inside the body to guide that wire or that device to do the treatment.
Well, we'll get more into that later because I'm very curious. I want you to sort of put us in that operating room and what you're looking at and what you see in the patient. But before we get to that, so it's a new surgical specialty. It's about 10 years old. So as it grew, what are the things that it's used for? And from what I understand, certainly many, many ways to use it for cancer patients, but also other applications for non-cancer patients.
So there are a lot of patients that can have bleeding from benign causes, meaning trauma, somebody has a car accident or something like that, or gastrointestinal bleeding from their stomach.
So this is internal bleeding.
Internal bleeding. And also from cancer. Sometimes cancer can erode into blood vessels and it can bleed. And a lot of times these patients are too sick to have large operations to address that. And the beauty of the treatments that we offer those patients is that we can, create a pinhole incision, as you mentioned, go in with our catheters and wires, find where the bleeding is coming from, we plug it, and we leave. So it's minimally invasive as it gets, and it's extremely effective. And in fact, it's one of the most rewarding things I do when I get called at 3 a.m, patient's bleeding and they're dying, and we go in, and as soon as we treat them, they're not pale anymore, their blood pressure starts going up, their heart rate becomes normal, and it's that feeling where you're able to help in most of the dire situations is just very rewarding.
Wow, that's fascinating. You tie off all the bleeding veins and arteries, and the skin color changes as the blood circulates throughout the body again.
Exactly.
That's
and you
cool.
actually see the impact on their vital signs, is what we call it, the blood pressure and the heart rate, and in real time. As soon as you treat them, and they're getting obviously resuscitation with blood products, etc., because the bleeding stops, you can see in real time that they become normal and they're no longer in a critical stage. So.
All right, I'm starting to get a sense, and I'm starting to be able to visualize what you do. So give me another example or two. Let's do some more non-cancer examples before we really dive into cancer ones. So what would be another sort of procedure that you do on a fairly regular basis?
On a fairly regular basis, we do, for example, patients who have abscesses or pockets of infection in their body. And sometimes they can be, they can be sick, but sometimes they can be very sick, or what we call septic, where the infection goes into their system and they can get really sick. And a lot of times, that would require big operations to open them up and clear that infection. Or we can, in interventional radiology, we can go in, numb them up, make a tiny incision, use imaging like x-rays and ultrasounds, etc., to see inside the body, place a small drain, get that infection out, remove the drain in a couple days, and the patients are, along with antibiotics and other treatments, they recover remarkably well.
So I'm trying to visualize this. So when you say you use an imaging machine, what are you looking at? Is the screen is right there and it's giving you real-time pictures of what's going on inside that patient's body?
Exactly. So I can see inside the body with a CAT scanner, for example, or an X-ray machine, or with an ultrasound machine, and that helps me do minimally invasive work inside the body without opening the body to see what's inside. And so the whole point of my specialty is to be in and out to fix the problem without, leaving, much damage to the body. So in and out, and it looks like you're not even ever there.
Yeah, so instead of having a 12-inch scar and 3 nights in the hospital,
exactly,
you don't have that. And then I'm trying to picture when you insert the thin wire that you said had a way to sort of suction out the abscess. you can see that. You'll see that in real time too as it goes in.
Absolutely. We see the wire. There are other devices we use, but the wire is what we work, the railing that we work over, but we use sometimes needles. We use balloons to expand, blockages. We can place drains, and those are like tubes that drain to the outside, and then when they're done, we take them out. All sorts of, technologies that we have.
So there's all sorts of little tubes and wires and
Exactly.
devices that have been developed to help you do what you do that are really tiny and really effective.
Absolutely, and that's what is really exciting, because the technology, there's no limit. If you can imagine something that you need to fix a medical issue, you can make it.
We're going to take a quick break because that was a great overview on interventional radiology. And when we'll come back, we'll talk about how it's applied to cancer patients.
You didn't choose cancer, but you can choose where to treat it.
And when you choose the James at Ohio State,
you're picking a team of experts who understand there is no routine cancer.
You're opting for care from a highly specialized team dedicated to treating one type of cancer, yours.
A team that studies the unique makeup of your disease to develop a personalized treatment plan.
You're choosing our region's only comprehensive cancer center designated by the National Cancer Institute.
Where more than 1,700 scientists are working on new treatments and new hope for every form of cancer.
At the James, you're making the choice to have the most advanced treatments, many of which were developed right here.
And you're choosing access to the James world-class clinical trials, dedicated support services, and an unmatched survivorship program to support your life after cancer treatment.
You didn't choose cancer, but the choice of where to treat it is clear.
We're back with Mina McCary, a specialist in interventional radiology, and you gave us a great overview on some of the different ways, particularly the non-cancer ways it can be utilized. But now let's dive in and talk about how you're using it here at the James to treat cancer patients.
Absolutely. So one of the privileges that I have when I treat cancer patients is that I have the opportunity to be part of their journey from beginning to end. And, when patients come to us as part of radiology, we're able to diagnose their conditions with imaging, x-rays, and CTs and CAT scans and MRIs, which we read and contribute to that. We also perform their biopsies, so we can use x-ray, CTs and ultrasounds to look inside the body, and if there's a lung mass or a kidney mass or in other organs, we can go in and get some samples so we can figure out what the disease is. And then we work with our oncology colleagues and surgeons and radiation oncologists and others to come up with a treatment plan. And if the treatment plan involves chemotherapy, for example, many patients get ports, which are devices where they can get their chemotherapy, and we have the privilege of doing that.
So when you say that a patient comes to you, I'm just curious, is a patient come to you directly, or would another James oncologist say, oh, you know what, this is something that interventional radiology would work really well for. I'm going to recommend this patient to Dr. McCary.
Almost all the patients come referred to me from oncologists, whether at OSU or outside. But we also participate in tumor boards and interdisciplinary discussions, as a team. And we're active in those discussions. So in those interdisciplinary meetings where multiple experts from across the board participate, when a patient comes to OSU, we can contribute to that decision making as well directly. And then occasionally, sometimes a patient will find something on imaging incidentally, or will diagnose something, and then we get the ball rolling. But it's always a team sport.
But it sounds like, because you said it's a relatively new specialty, right, and maybe not particularly at smaller hospitals that treat cancer patients, they're just now starting to learn about what you can do, and they don't have an interventional radiologist, but they know, oh, wait, the James has one, or a team of them. So that's how people are starting to flow to you.
Absolutely. And even in other institutions that have IR, they don't always necessarily have the full spectrum of IR. We have the opportunity at OSU to offer the full gamut of interventional oncology, including the newest treatments that might not always be available elsewhere.
Yeah, you have one of the biggest and best programs in the country.
Expertise and resources to do those treatments.
Yeah, that's the advantage of having being part of a comprehensive and large cancer center and research center.
Absolutely.
So before I got off on a tangent here, you were starting to explain some of the different ways that it's used for treating cancer patients. So continue on that path.
Oh, absolutely. So if it's, if the decision is for a patient, for example, like I said, to get chemotherapy and they need access or access like ports or other lines or long IVs that we can put in them so they can get the treatment, we have the privilege of placing those devices in the patients. If the decision is to actually treat, then in IR, then we have a variety of options. So, for example, we have something called ablation, where we can place one or more probes, which are small needles, in a patient, and we can freeze or burn a tumor. And obviously, it's not offered for all tumors in all stages, but when we do that, we can actually cure that tumor in real time. So it's actually one of the most rewarding things that I do, because a patient comes in the morning with, let's say, a liver cancer, and I can ablate it and I treat it, and they go home the same day with a Band-Aid and cancer-free. So that is just extremely rewarding treatment that we do to patients.
Wait a second, I got to wrap my mind around this. So someone has liver cancer tumor.
Yeah.
Let's just say it's a small tumor on their liver, not the whole liver. That might be a whole different
Correct.
situation. You go in, freeze it. What happens when you freeze it? That kills the cancer cells?
Yeah, so typically in what you're describing, I would use heat. So I would heat it up, and I basically would burn the tumor and a small margin around it. And the probes that we use to do that, usually I would use one, which is so small that we don't even need to stitch anything at the end. We just put a Band-Aid. And obviously, it's not all stages of tumors and not all locations of tumors. But for patients that can get it, we can have really good outcomes.
So what types of tumors, and is it, if they're over a certain size, will it not work? It has to be smaller tumors?
It depends on the size of the tumor. It depends on the location of the tumor. It depends on if they have one or more. It depends on the patient's, what we call comorbidities. It's a pretty safe procedure, but for this specific procedure, we have to put them under general anesthesia so they're comfortable during that time. So if they can handle that, it depends on a few factors, but we've been able to offer to many patients that are candidates for it.
Wow, this is a fascinating way to treat cancer. Give me a couple examples of, you gave one of liver cancer. What are some of the other cancers that you've treated with this? And is it, I thought you said freezing before, but then you said heat. Or can you do both of those techniques?
Yes, so you can freeze or heat, and it depends on the organ, and it depends on there's benefits, there's pros and cons from a technical perspective, and cryo ablation is the freezing. You can see the ice ball in real time, so you have better visualization, but you may have to use more probes. The heat, for example, you might get away with one or two, but it's better for other, if you have a safe distance between the tumor and other critical structures. So there's a lot of factors we think about. But to give you another example of other organs we treat, I treat kidney cancer. I treat lung cancer in certain cases. I also treat patients who have tumors that are benign, but they're causing pressure on their body, and we're trying to shrink them. So, for example, desmoid tumors, which are benign tumors that can develop, but they're hard to control sometimes. We can freeze those tumors, and those are the main ones we do so far.
Wow, that's amazing, because, there's scores of kidney and lung cancer surgeons, specialists here at the James, some of the nation's best. But what you do is something different from what they do. So I take it you'll collaborate with them in deciding when to do a more traditional surgery or when to do interventional radiology.
Oh, absolutely. The collaboration is key here, and I talk to oncologists and surgeons on a daily basis, and a lot of my colleagues and my friends too, and that's how we can get best patient care, because we put our minds together and try to find the best treatment for a specific patient. Not all patients, even with the same tumor, are the same. And not all tumors, even if they're the same size, are, every tumor behaves differently. So the best way to get the best treatment plan for a patient is to work together with other specialists to find the personalized treatment plan for that patient.
Yeah, definitely. And you're just you're having more options to have better outcomes.
Exactly.
So, okay, so we talked about port placement. And just in case people don't know, ports are sort of for people who have regular chemotherapy, it's a little device planted in their chest. That way, and the medicine goes through there, so they don't have to inject into people's veins over and over and over. And it's a real surgery to get those in. So that's a big advance. And then with ablation, with this freezing or heating of small tumors in kidneys, lungs, sometimes benign ones. So that's a lot already. Mm-hmm. So what's next? I'm sure there's a few more things that you do, and I'll bet you there's more that you're working on developing new techniques.
Oh, absolutely. There's much more. So
we're just getting started.
We're just getting started,
That's
Steve. And this is what excites me about my field and being able to help patients and offer them a variety of options. So in terms of treatments, we talked about ablation type treatments. And then there are also another group of treatments, we call them catheter directed, which are basically back to the traditional IR where we go into blood vessels. So we make a tiny pinhole incision, and usually in a vessel in the groin area where we go in, and then we use wires and tiny catheters, and we find the blood flow to that tumor, and then we can inject microscopic beads that block that flow to the tumor, so we deprive it from flow and oxygen. But also sometimes these are coated with chemotherapy, so instead of giving chemotherapy that goes in their entire system, it's directed exactly at the tumor. Sometimes they're coated with radiation, so we give them, radiation directly into that. And this can be done primarily for the liver at this time, but it can be used in other situations as well. And that's a whole new world where we can offer patients directed treatment, and we call it local regional treatment, by giving the whole punch directly at the doorstep of the tumor. And we can use multiple mechanisms to do that, depriving it flow and sometimes chemo and sometimes radiation right there.
So when you deprive the flow of blood to a cancer tumor, it's going to die.
Exactly. It's going to shrink and die.
It'll shrink and die. Wow. And that probably works best when it hasn't metastasized?
Most of these treatments are done when, talking specifically about the liver, when we have liver predominant disease. Some of them are done with the goal of curing the cancer or getting rid of it. Some of them are done for the goal of palliation, to control it, because the liver is a key organ in the body. If you have tumors in the liver,
right,
you can't live a long time without a liver. So we have to do everything we can to keep the tumors under control. And sometimes it's for symptoms. If those tumors are secreting hormones and causing symptoms in patients, for example, in neuroendocrine tumors, patients can get flushing and nausea and other symptoms. We can treat the liver, and patients get improvement in their symptoms.
So one of the big improvements here is that instead of cutting out the tumor and along with it a piece of the liver, you don't have to do that more invasive surgery. You're cutting off the blood flow, and the tumor goes away, hopefully by itself. So that's a big improvement.
Exactly. And sometimes we can get something called a complete response where the tumor goes away, but sometimes we get something called partial response where we can shrink it or control it. So these treatments, some of them can be treated as many times as needed, so it's not a one-time. And some are one-time and some are not. So ablation is a one-time. Some of the catheter-directed therapies are one-time, but sometimes they're not, and the patients might need multiple treatments to keep things at bay, and that's how they work.
And so far, you said the liver is the predominant organ in which this is done. Are there trials to try it on other organs?
So there are other institutions and other research teams working on, for example, the radiation one I was telling you about, where we have these particles or beads that have radiation on them. There are some groups that are looking at applying that to prostate cancer. There are some groups that are looking at applying that to brain tumors, and where instead of radiating the whole brain, finding the flow to the tumor and inserting it there. And there's a whole lots of progress to be made, obviously.
Wow. Okay. As you mentioned, there's a lot more. So what's next on your list?
So what's next on my list? So we talked about diagnosing, we talked about treating, and then palliation. So unfortunately, some patients...
Palliation means reduce pain for people whose cancer is terminal.
Exactly. In patients where we unfortunately cannot cure their cancers, but we want to improve or maintain their quality of life, we can actually do different treatments to address that. And
which is really important, because people can be around for a while and you want them to have the best quality of life they can.
Exactly. And usually in many of those cases, there's not a whole lot that can be offered, but fortunately with IR, along with our colleagues from palliative medicine and in other areas, we can offer treatments. So for example, patients have blockages in their organs that are causing symptoms. So tumors in the kidney or in the bladder or in the prostate that are blocking the kidney, and patients are getting pain and back pressure and all that, we can place drains in the kidney to drain that urine and help them feel better. Or in the liver, or interventional pain procedures that we can do to ablate or treat nerves that are causing pain. Or vascular, so regarding vessels, blood vessels like veins. A lot of times patients have blockages of veins when their cancers grow, and that can be...
Cancer blocks the vein.
Exactly.
It pushes against it and... Okay.
Absolutely, yeah. It's if you think about it, it's like a mechanical obstruction. The vessels are the plumbing, and you have a big mass or rock or something pressing on it, and that pipe gets blocked.
Yeah.
Unfortunately, there's no treatment, no effective treatments often for those patients, because at that point, they're not candidates for surgery, and it's palliation perspective. So one of the things that we can do that can often be life-saving is we can build those veins, and it's called venous reconstruction. We can make tiny incisions, try to cross those blockages, and try to build those veins with stents and balloons and other devices.
Wait, so you mean if there's a blockage in a vein, you can unblock it, or you just almost create an alternate route around it, or both?
That is a fantastic question. So if the vein is still preserved but compressed, we can open it up. If the vein is gone, we can actually try to go through that similar path or where the remnant or the previous vein was, and actually build a new vein right there.
How do you do that? How do you build a new vein?
We use grafts and stents to address that.
From the person's own body?
No, they're covered stents. They're prosthetic materials.
So, there's prosthetic veins that you can put in someone?
They're stents, so stents are like metal pipes, and sometimes they're uncovered, and sometimes they're covered where you can.
So you have a space between where the vein was broken,
right,
and you insert a metal stent to connect them.
Exactly.
And then the stent is uncovered, but it just flows through.
Exactly, and sometimes you need uncovered, and sometimes you need covered. Depending on the situation.
Oh, if it's touching something that you don't want the metal to touch, or
exactly, or if you don't, if you don't want, if it's, let's say it's a tumor and you don't want the tumor to protrude through the stent, or there's a lot of technical factors depending on the size of the vein, location, pressure, extrinsic pressure. Some of these have something we call radial force, like how much it stays open. So there's a lot of science that we think about when we make those decisions.
So I'm thinking in my mind of like a creek that goes underneath the road. They build the road over it, and they put one of those big round pipes.
Exactly.
That's sort of what you're doing. It's the pipe that connects the two sides of the creek.
It's all about plumbing, Steve.
Yeah, but yours is a little more high tech, and but I like I said, that's a really simple way to describe it. But this is really high-tech, complicated surgery that requires a lot of manual dexterity and skill.
Absolutely, and a variety of risks and techniques and expertise to do these. But they're really exciting because those patients have no hope and no options otherwise in most of the cases. And sometimes these blockages, or when the veins are gone, can be even life-threatening. So you end up with a patient who's very sick and they have no options, and being able to do these procedures give him hope.
So this surgery that you just described, the venous reconstruction, you have imaging that shows you what's going on inside, and you can't see inside with your own eyes, so you're looking at the screen, And how are you? And so you have to look at the screen, but then your hands are working independently to manipulate these devices. I mean,
Absolutely.
that sounds like a skill, a craft or a skill that takes. How do you learn how to do that?
Lots of work and hours and practice. The way you phrase it is right on point there. You could be even standing by the patient's leg, manipulating these microscopic wires in your hand, and affecting, those wires and catheters are, near their liver or heart or somewhere else, and you're manipulating them right there, and you're looking and you're coordinating that, not just with what you see, but also with the tactile feedback. That's a huge thing. Sometimes you can feel with how a wire is passing or how a device is deploying, and that's a huge part of being a good or expert IR.
Oh, you can tell if it's going in easily or if it's hitting an obstruction.
Exactly, and you can actually tell exactly what's going on by that tactile feedback, and that's what I teach my fellows and residents, because that what differentiates you from not just being a good IR, but being successful, because some of these procedures are near impossible, and you're trying to go through blockages safely and not, cause issues. So it takes integration of understanding of the anatomy, understanding of patients' anatomical relationships of their organs from prior CAT scans and studies they had before the procedure, plus in real time the imaging that you have, plus the feel, plus your experience, plus the expertise in the equipment that you have.
Wow, that's why it's near impossible, because that's complicated.
It is.
And when you do it, when you have a something that's blocked, a vein that's blocked, you unblock it, connect it, and the blood suddenly flowing through it, then wherever in the direction it is traveling, do you see the blood flow and open up all these little veins and arteries going throughout the body?
Absolutely. In fact, one of my favorite things to do is after one of these procedures, and some of these can be 3 hours, and some of them can be 20 hours. That's how long.
20.
The longest I've had. Most of them, luckily, are not that long. But just to give you the range of, if you're building somebody from, I've taken care of a patient who had blockage all the way from their heart all the way down to their legs. That was the one I'm referring to, the length. But most of them are shorter than that. But one of my favorite things to show those patients after the procedure is to take the pre and the post pictures that I save and show them.
And it looks like tree branches going out are suddenly there, right?
Absolutely.
There's nothing there, and then there's all these branches of blood and circulating.
Exactly. And ideally you could even, I try to do, what I do is I will cover the before imaging, and I tell them, if anybody looked at this picture, they would have no idea that you never had veins. Your veins were blocked. And that's as a the characteristics of a good reconstruction is it looks as normal as it gets.
So that's pretty amazing, particularly the venous reconstruction. And I can picture it in my mind of these veins opening up. So as you mentioned, we're only 10 years in to this being a specialty, which is really new in medicine and in cancer. So what's going to happen next in terms of how much bigger it'll get in terms of doing procedures and new types of procedures that may be down the road that you're going to learn and perfect?
Absolutely. The future is bright, Steve, and everybody that's in this field is really excited about what's to come, because the future of medicine is minimally invasive, quicker recovery, less risk of complications, and cost effective. When we have any procedure, any treatment that has these characteristics, that's how you can have a huge impact on patients and improving quality of life.
Yeah, and it sounds like as it becomes a more known, there's more people who do what you do, that in labs around the world, they're going to start designing things that will help you, like better ways to get the radiation directly in, better chemo and immunotherapy to go right in. Is that true? Are there sort of new drugs and things that you can put in through interventional radiology that are going to make it even more effective?
Absolutely, and not just we're scratching the surface. So, for example, the treatments that we do the liver, where we inject beads and they can have chemotherapy or radiation. There's two developments now. Some groups are working on the role of immunotherapy as an embolic agent or as a treatment agent in those types of procedures, to see if we can actually just deliver directly there what impact we see. So that is very, very, very exciting. There's also new development in the radiation part, something called radiation segmentectomy. And it allows us to, instead of radiating a big part of the liver, we can focus our radiation even more and deliver more radiation via the catheter. The outcomes from this are curative in most cases, so it's almost like doing big surgery without a surgery. That's why they call segmentectomy. It's like removing a segment out, which is a big surgery, without doing a surgery. So that is very exciting in that world. Ablation technologies have been evolving all the time with newer devices and different power and different techniques. And then also being able to treat other organs and offering hope to other patients.
Wow, thanks. That was a great overview. And I take it, as a pioneer in a new technology who gets to, like you said, you're from A to Z when you're with the patient, from the beginning to the end of their treatment, that must be what fuels you to do this.
Absolutely. That's what I'm passionate about, actually, and this is why I do this. And some of these procedures are straightforward and some are more complex, but what gives me the energy at the end of the day is, after I'm done with the treatment, going back to the patient and their loved ones and telling them what happened. That is priceless to me, especially at the end of an ablation day, for example. And I'm saying, congratulations, we treated your tumor. You're cancer free, and they go home with a Band-Aid. The incision was so small, you even have to put a stitch in there. That, to me, I could see that being my dad or my family or me being in that position, and being able to deliver hope is just something that is very, very rewarding to me.
Well, thanks for sharing that, and thanks for your passion.
Thank you, and thank you again for the opportunity to be here today, and I'm looking forward to more exciting treatments for our patients.
Okay. This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur D. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.